Let's turn our attention to our fourth learning objective and discuss the treatment of SIADH. The treatment for SIADH is primarily limiting fluid intake to less than 2 liters per day. This is done to limit the amount of free water available to be reabsorbed at the collecting ducts. Most SIADH patients have a mild hyponatremia and are asymptomatic, so limiting fluid intake is usually a sufficient treatment. However, there are cases where serum sodium can fall to less than 125 milliequivalents per liter, which can be dangerous to the central nervous system. If serum sodium is under 125 milliequivalents per liter and/or the patient has CNS symptoms such as seizure, visual disturbances, or coma, aggressive management is indicated. Now, the most aggressive form of sodium replacement is using hypertonic saline infusion, which is saline available at 3% and 5% concentrations. The use of hypertonic solutions should be reserved strictly for patients with serious neurologic manifestations of hyponatremia. Also, these solutions should always be administered with close monitoring of patients' electrolytes. It's important to remember that sodium correction should not exceed 1 milliequivalent per hour or 10 to 12 milliequivalents in a 24-hour period due to the risk of developing central pontine myelinolysis. Now, central pontine myelinolysis is also known as osmotic demyelination. Is a condition where there is damage to the myelin sheath of neurons in the brainstem, which leads to demyelination of these neurons. Patients usually present with acute para or quadriparesis, dysarthria, dysphagia, diplopia, and loss of consciousness. Rapid correction of hyponatremia is the most common cause of central pontine myelinolysis. Other causes include alcoholism and hyperemesis gravidarum. Treatment is usually supportive. Demeclocycline, a tetracycline antibiotic that has anti-vasopressin properties, can be used in cases requiring urgent treatment.